afternoon. Thank you for joining us and welcome to this next and final session for PCN Live. I hope you managed to catch some of the sessions this week. It's been a really fantastic event. And our next session is focused on venous leg ulcers and in particular the skin and assessing and managing the whole of the lower limb. My name is Janine Davis. I'm a clinical specialist, a consultant clinical specialist with Everland Pharma, and I also have an extensive background in primary care, especially in leg ulcer management and wound care. And Everland Pharma have very kindly sponsored today's event for you. So I'm going to be taking us through the presentation in just a few moments, but first I'd just like to do a little bit of housekeeping. So just to let you know, in front of you, you should see a Q&A tab on the top right of your screen. If you have any questions as we go through the presentation, please just pop them in there and I'll try my very best at the end to try and answer them. We should have a short amount of time to do that, and anything we don't get through I can pick up later. Just to let you know that the session is being recorded today and it will be available on demand afterwards. So if you don't manage to catch the whole thing, don't worry, you can go and catch up on that in your own time. Always a question that's asked, CPD certificates will be emailed to you directly within 1 month of the event. And really important, please do complete the feedback form at the end. It's invaluable for the organisers and also for us as speakers so that we continually improve. As I say, feedback is a gift. So we have quite a bit to get through. Without further ado, I think what we need to do now is to move on and to show you our main presentation, and I will catch you at the end when we can take up some questions. Enjoy. Good afternoon and welcome to this primary care nursing event brought to you by Practice Nursing Journal and Independent Nurse. Our session this afternoon is on venous leg ulcers and specifically assessing and managing the whole limb. And as the saying goes, not just the hole within the limb. So my name is Janine Davis and I'm a registered nurse with an extensive background in wound care and leg ulcer management. And I'm now a consultant clinical specialist working alongside Everland Pharma, who have kindly sponsored today's talk. So in the session, we're going to be looking at venous leg ulcers and getting the best out of your holistic assessment. But in addition to thinking about the actual ulceration, we will also focus on the rest of the limb and the associated skin conditions that we often see. And sometimes the condition of the skin can be as difficult to heal as the actual ulceration itself. So we do need to make sure that we treat and manage the skin tissues in addition to the ulceration. So today we'll be taking a very clinically focused look at all the things that you should be thinking about and looking for when assessing your patients. And I always think of it as almost like being a detective. You're linking all the different signs and symptoms together to provide the very best and most appropriate care for your patient. What I don't plan to do today is to talk about the actual vascular assessment process or the different types of compression, because I think that's for another session. It's a far bigger topic. But we'll base our talk around patients who have a confirmed venous diagnosis and probably assume that they're already wearing compression therapy. But towards the end of today's session, I'd like to provide you with some really valuable information on how you can help to heal the ulceration and at the same time effectively deal with the skin conditions as well. And that would be using the power of zinc oxide and ecthamol to aid healing. And then at the end, there'll be an opportunity for questions. So we know that many ulcers develop from an injury to the skin, and often that might be a very minor injury that allows air and bacteria to get into the underlying tissue. And fortunately for most people, this will heal up within a week or two. However, where the patient has an underlying problem that perhaps they don't already know about, the skin doesn't heal and the area of breakdown can increase in size, creating a more chronic problem. The most common problem is disease of the veins, and that goes without saying, and therefore venous disease accounts for over 2/3 of all leg ulcers. And it's estimated that around 280,000 people every year have a leg ulcer. So that's a lot of leg ulcers, and that's also a lot of work for all of you. And therefore there's a very great need to improve care and to get these patients healed as quickly as possible. You can see on the slide that we're presenting here that according to the Vascular Society, around 8% of ulcers are due to venous etiology, with 15% arterial etiology and 5% due to other causes. So, for example, rheumatoid arthritis, diabetes, or perhaps some of the more rarer causes of ulceration. And of course, it goes without saying that there can be 2 or more conditions that are causing damage at the same time. And so your holistic assessment and vascular diagnosis is absolutely crucial. So wound and skin assessment is a key component in effective wound management, as it can provide useful information towards diagnosis. It can help to guide your choice of appropriate dressings or therapy, and it also provides the ability to monitor progress or to monitor problems within the healing process. And just thinking about the wound itself for a moment, as we already know, wound healing normally follows a very well-defined but complex series of cellular and biochemical interactions, which are affected by local and systemic factors. And so there are numerous opportunities for the wound healing process to be halted, especially where we're managing patients with leg ulcers who also have other potential comorbidities. So as a result, we need to use as much information as we possibly can each time we assess these patients to really identify what's going on. And we know that time is always in short supply, especially recently with the pandemic. But can you always say that you take the time to fully assess your patient every time you see them? So we need to ensure that we don't fall into the habit of just applying something to the patient just because the care plan actually says to do so, and somebody else maybe wrote that care plan. And we really need to use all of our knowledge and skills and expertise in leg ulcer management to make informed decisions and to provide the very best care and choices for our patient. So I've worked with patients with leg ulcers for many years, and for me, an assessment, I personally like to think about an assessment as a 3 Ps approach, which overall takes into account the intrinsic and extrinsic factors. And so what do I mean by the 3 Ps? Well, that would be the predisposing factors, the perpetuating factors, and then the presenting factors. And most assessment documents, whichever you use, contain this information in various guises. However, for me, this approach just simplifies things. So if we don't get to the root cause of the condition and therefore we don't address it, then we increase the chance of recurrence and ongoing issues. And with estimates of treating a patient with a venous leg ulcer at probably around £1,000 a year under normal circumstances, then if we don't heal them, those costs will escalate dramatically. So that's something we need to try and avoid. So just before we think about the wound and associated skin conditions, I'll run you through a quick overview of what I mean by the 3 Ps. So first of all, the predisposing factors. You probably think, well, that's fairly simple. We need to think, it's just stuff that we write down on an assessment chart. But I want you to really think about it, what it means for your patient. It's not just about adding a name and a date of birth onto a form, but things like age and gender are important predisposing factors. We know that already, that at a younger age, numbers of patients with venous leg ulcers are probably fairly equal between men and women. But in later life, more women than men will suffer with a venous leg ulcer, and that might be because of things like pregnancy and things like that in former life. But also think about things like their mobility. What are their predisposing factors? How well can they get about? Can they get about at all? What's their environment or the social setting? Do they live alone? Have they got carers? What's going on in their world? And then mental state and awareness and attitude with your patients. I think this is a really big thing and probably something that's a little bit underestimated. And at this moment in time with the pandemic, we know that we've probably all become less mobile and less active. We've kind of become cocooned in this world of lockdown, which undoubtedly affects how we're living and how we're also thinking and feeling. So perhaps as nurses, we could get a little bit better at exploring our patients' perception on their wound or condition. Why do they actually think the wound's there? What is their understanding and their current knowledge of their own issues? Do they suffer with depression? As we know that can impact on how they're living their life, especially having a knock-on effect on things like diet or sleep, for example. But what about attitude? Are they actually prepared to help themselves and to improve their own situation? So there's really lots to think about on a psychosocial level. And then other things that are predisposing factors. Weight and diet can be a huge factor in healing, and malnourished patients will often need support. And when I say malnourished, I don't just mean the smaller framed, maybe emaciated patients that we sometimes might see, but the more obese patients may need support to find nutritional balance. We know for heel wounds, we might need a diet that's high in proteins and high in fat, for example. But for those patients, dietary input might be necessary just to find an absolute balance. But I'll touch again a little bit on diet a bit later. So in terms of predisposing factors as well, habits are something to think about when you're assessing your patients. Explore around their alcohol intake. You know, how much are they drinking? Also, their smoking habits. Current pressures might mean that their habits have increased, so they might be smoking a bit more than normal. I mean, not only do we know that smoking's a major risk factor for the development of lung and heart disease, but it adversely affects wound healing. Did you know there are 600 ingredients in a cigarette, and when they burn, they actually create about 7,000 chemicals? It's absolutely astonishing, and around 70 of those are known to be carcinogenic. But 3 of the most toxic components of cigarette are nicotine, carbon monoxide, and hydrogen cyanide, which all contribute to tissue hypoxia, which is brought about by vasoconstriction. So we know that these things can seriously impair the physiological and chemical processes that should naturally occur during wound healing. So we need to help these patients and provide the education and services that they need to stop or at least reduce. So that's just a little overview on the predisposing factors that I like to think about. So on to perpetuating factors. So I think of this as the things that are actually ongoing with the patient. So maybe things like hypertension. We know that a lot of our venous leg ulcer patients have a problem with high blood pressure. So how well is that controlled? Do they need medication reviews? We know that some of that has slipped during the pandemic, undoubtedly. But what does the haematology picture look like? For example, their full blood count, their lipids, blood glucose levels, etc. And what's the history of the ulceration? Or also, what's the history of previous ulcerations? Have they had any venous or arterial surgery since maybe you saw them last time? Do they have allergies or sensitivities? As we know that for many patients who have spent a considerable amount of time in bandages, they're easily sensitized to all manner of products, lotions, potions, etc. Do they have varicosities? Are they a problem for them? Always stand your patients up to assess the extent of varicosity so that the vessels fill and give you a full picture. They might actually need referral to the vascular team for treatment when things settle down a little. But crucially, what does their vascular assessment tell you? I did say we're not going to talk about that today. We're not going to go into the ins and outs of the actual process. But how often do we reassess this? We know we can't do that every time we see the patient. But what little checks can we do on a regular basis just to reassess? Are there any significant changes to accommodate? Yes, time is always short, but where healing is delayed, it should never be a one-stop shop for vascular assessment. Please reassess as often as required, and that might be just things like looking at pulse oximetry or capillary refill, just pinching the pulp of the toe to see how quickly it refills, or listening to the pedal pulses to establish the waveforms. Are they triphasic, biphasic, monophasic? So let's make sure that we think about all of these things every time we see our patients and we regularly reassess. So now on to the presenting factors, kind of where we get to the juicy bit. Of course, we're predominantly concerned with observing the ulceration itself, but I also really want to talk about the rest of the limb and skin and what we most definitely should be looking for when we're looking after these patients. So before we even get to thinking and examining the wound, observe the whole of the limbs, the shape, the edema, look for signs of staining, induration, lipodermatosclerosis, I'm so pleased I managed to say that, ankle flare, varicosities, and the exact location of the wound, and note them down. Note all of them down, as much information as you can possibly pop on your assessment chart. Whatever your wound and leg ulcer assessment documentation look like, it's likely to include things around the actual wound, like the tissue type, whether there's slough, whether there's debris. Slough and debris builds up on the wound bed on most wounds, and this consists of old dead cells which need to be got rid of, as does any necrotic tissue. And we know that autolytic debridement is very slow, and therefore we usually need to help this along with the use of products, so we need to speed that up a little bit. So we need to look closely at the wound bed to identify whether it's actually infected as well. Okay, so have a think about what's going on there. Is it quite a new wound which is still in the inflammatory stage of healing? Remember, that's around 5 to 21 days. So if it's quite new, the chances are it's still in its inflammation stage. Or if it's a chronic wound, is it stuck in the inflammatory stage due to something which is halting the progress of wound healing? Remember, we talked about the local and systemic factors. And that's where we need to look at exactly what is causing the lack of progression. So local and systemic factors, this could be actual local factors within the wound, like slough or desiccation and drying out, or it could be systemic things like tissue perfusion, disease, maybe diabetes or smoking. Sometimes environmental factors come into play as well, like the environment that somebody perhaps lives in, contamination, or even patient behaviours. Are they having a good old poke at the wound every time you turn your back? So please do check closely for infection. Look for darkening of the wound bed, increased pain or malodor, erythema around the wound, which might be tracking away from the wound. And obviously, if you suspect that, swab it and treat accordingly with antibiotics if appropriate. And moisture levels. What are the moisture levels like? Are they too high? Or maybe they're too low. We actually need exudate within a wound, as it's where all the biochemical activity takes place. However, if the levels are too high, it could be a sign of something else, like infection, for example, which needs to be managed. So I just mentioned maceration actually, and that's quite an important thing to think about with the high levels of moisture. With our venous leg ulcer patients, maceration of the skin around the wound, and in fact the whole of the lower limb actually, where gravity causes fluid to run down the leg and sometimes right into the heel cup, it can really be a common problem. It causes discomfort and irritation for the patient, and at its worst, it can actually lead to further ulceration with extension of the damage into intact tissue. So normally, the epidermis forms an effective barrier and actually waterproofs us with its keratinized cells. It protects the body from fluid loss and from bacterial invasion, but where there's prolonged exposure to high levels of moisture or corrosive body fluids, which are full of MMPs and proteases, the skin surface can become breached, and this will result in maceration. So where we see the soggy, white, wrinkly tissue, which just can't hold any more fluid. So a little bit like what you see on the slide here. The outer keratinized layer of epidermal cells becomes swollen, the bonds between the tissue planes starts to weaken, and this will then alter the cell's ability to withstand damage, so like, for example, friction. So where maceration is particularly bad, the epidermis is sometimes stripped away, exposing the fragile layers beneath, which of course is really, really painful and sore for the patient, and could really increase the risk of further damage and significant secondary infection from bacteria and fungi, which just absolutely love to multiply in all that fluid, which is so full of protein. So whilst we need exudate, for all the biochemical activity of wound healing to take place. Too much of it can be a real big problem. So please don't dismiss it and hope that it will just settle. Let's actively try to manage that fluid by continually assessing, trying to understand what's going on and applying therapeutic levels of compression to protect those delicate skin tissues. So just make sure that the moisture isn't elevated due to infection. Choose an appropriate dressing. You know what's on your formulary, and obviously compression as indicated from your vascular assessment. And then moving on, please always look at the wound margins or edges. How are they looking? Are they actually progressing across? Can you see that lovely silvery layer of epithelial cells developing around the edge of the wound? Or are they retracting with chronicity? We need to be noting all of these things down. And if we can get all of the other elements in healing right, then the edge of the wound should look after itself and progress to cover the defect. So it's fairly simple, isn't it, really? There is an awful lot to think about. So just to kind of cover that again, predisposing factors, the perpetuating factors, and then think about the presenting factors when you're assessing your patients that present to you with a venous leg ulcer. So now I want us to think about the rest of the leg. And this is really every bit as important as the wound itself. As I said before, for some patients, the skin can be as troublesome to heal as the wound itself. I'm sure that you can think of lots of patients that you see that have these issues with skin as well as the wound, and you almost feel like you take 2 steps forward, 1 step back sometimes. The road to full healing can be really lengthy and challenging. So what I want to do now is to pick up on, first of all, some general aspects of skin assessment, and then some skin problems which are particularly related to venous leg ulceration. So, first of all, key thing, it seems an obvious thing, but look at both limbs. You'd be amazed at how many people will just look at the affected limb, but please ask your patient if you can look at both of the limbs. It's so important for comparison. Obviously, I explain the reason for this for the patient, but you need to be able to compare both legs. So look at the whole of the limb, not just the lower leg where the ulceration might be. Whilst that might not be overly popular with your patient, it's really important because varicosities and edema can extend all the way up to the abdomen. So you need to check on that. Is it unilateral or is it bilateral, for example? And stand the patient up. Obviously, we need to lay them down for the vascular assessment, but stand the patient up to get better visibility of their limbs. How does what you see in front of you fit with their holistic and medical assessment? Pay particular attention to the toes and their nails for edema and looking for fungal infections. And also, don't forget to check the toe webbings. And when I say that, you're actually looking for fissures between the toes, as breaks can allow in bacteria causing ascending cellulitis. So really important to check. And people don't always make that connection between a fungal infection between the toes and what's going on in the limb. So it's really, really important that you think about that. Feel at the skin to assess the type and extent of edema. Are the legs tight? Is it pitting? What does the texture of the skin feel like? And just be aware as well, if you have a patient with a darker skin, people might sometimes have areas of induration, so that woody feeling, which aren't immediately obvious. So it really is important to touch and feel your patient's skin, obviously give them the reasons why you're going to be doing that. Again, look for redness on the limbs, or maybe on a darker skinned person, a bluish tinge. Look for scaling, crusting, exudate, excoriation, blistering, erosions, thinning of the skin, or pustules, and note everything down. Make a note of everything that's going on with these patients. And if there are multiple lesions present, are they all the same, or are there some real notable differences? Again, you need to establish between the differences in ulcerations. There might only be one, which is fine, but if there are more than one, do just check that. Does that patient have any known allergies which could be causing any skin issues? That's something to think about. Get your BNF out and have a look at that, or some of the medication if they're unusual ones. Could any of their medication be causing skin changes? Perhaps they could. And obviously one of the things that spring to mind are steroids. I mentioned thinning of the skin when you're looking at the legs. So steroids are an obvious one to think about. But note sensations as well. So ask your patient, are there any areas of pain? Is all the limb painful, or are there just some areas of soreness? Do they itch anywhere? And any apparent neuropathy? You know, have a little prod at the feet and see whether they express any feelings or not. So sensation is really, really important. So if you look at all of this, you'll be on your way to a really clear assessment. And honestly, as I said before, it's just like being a detective. I love it. So what I'm going to do now is focus on some specific skin conditions which are common to venous insufficiency. So first of all, one of the key things I want to talk about briefly is cellulitis. Cellulitis often affects the skin and tissues of the lower legs, and it's usually unilateral. Okay, usually unilateral. Cellulitis usually occurs where there's been a crack or a break in the skin which has allowed bacteria, usually staph or strep, to enter, and it causes the tissues to become swollen, hot and painful. Okay, swollen, hot and painful. Left untreated, the infection can really spread to lymph nodes and into the bloodstream, which causes real systemic malaise. The condition becomes much worse and the patient becomes really quite ill with cellulitis. So it becomes much more serious. They're quite sick. And people are often more at risk of cellulitis if they have poor circulation, so we know that, but also if they're overweight, which makes mobility difficult, or if they have a weakened immune system. So again, refer this back to your holistic assessment that you carried out. It's so very important. So cellulitis is very painful for the patient, hot, inflamed, and is usually treated with antibiotics, so typically flucloxacillin, amoxicillin, clarithromycin, coamoxiclav, one of those, maybe. They need elevation, gentle exercise, analgesia, and probably refrain from compression until the cellulitis and the infection settles. And once it's under control, it's really important then to establish a good skincare regime, which is required really to minimise recurrence. So sometimes, of course, hospitalisation is required to get on top of the infection with IV antibiotics, which obviously then impacts on the NHS and carries huge costs, not only for the NHS, but for the patient as well. So it's really important to manage these patients well at the very first sign of any developing cellulitis. Okay. So now, one thing that we all need to be mindful of with our leg ulcer patients is that we don't confuse cellulitis with red leg syndrome. Now, a diagnosis of red leg syndrome might be considered when a person presents, again, with a lower limb redness, which is usually bilateral. So remember I said with cellulitis, it's usually unilateral, but red leg syndrome is usually bilateral. So there's the first difference. They have swelling to the lower limbs, warmth and tenderness, but they don't have the feeling of that general malaise or sickness. Okay, so they're generally not unwell, but they have this red legs, warm and some tenderness. Again, it's commonly associated with patients who have a history of chronic venous disease or chronic edema, or dermatological conditions as well factor with red leg syndrome. So individuals who present with red legs are often misdiagnosed as having cellulitis and therefore are overtreated with antibiotics, and sometimes they're admitted to hospital. So you can see that there's a real problem there, obviously from a financial impact and from the patient's impact as well. So if you're treating a patient who presents with bright red legs, you should really assess these patients carefully, Consider differential diagnosis, and this is why the whole assessment process is so very important, and then treat your patient and the symptoms accordingly. And quite often, a red legs clinical pathway might be utilised. They seem to be popping up all around the country now. So maybe you have one in your own areas. If you're not sure, please ask about that in your own areas of work. So a red legs clinical pathway that you can use when you're diagnosing these particular patients. So where cellulitis has been excluded, symptoms may be treated as appropriate. For example, red leg syndrome is often accompanied by varicose eczema, dermatitis and fungal infections. So a good skincare routine is actively encouraged, including regular emollients, and the patient might need to be treated with compression therapy if they're not already in compression. So please, let's not confuse cellulitis and red leg syndrome. There's a lot of good information out there in the public domain now about red legs, so it would be really useful to take a look at that if you're unsure. So another big problem I'm sure you see on a regular basis, it gives us a few headaches, is good old varicose eczema, sometimes otherwise known as gravitational or stasis eczema. And as you probably already know, this type of endogenous eczema appears on the lower legs. It's related to poor venous return and usually high blood pressure in the limbs. So where the walls of the vessels in the lower limb are weakened due to lengthy high pressure, the movement of the blood back up the legs becomes very sluggish due to valve damage, creating further pressure in the vessels once the fluid starts to pool. It oozes through the vein walls into the surrounding tissue, causing edema. And over time, the blood leaks through as well, through the small vessels, causing the brown staining, which we see the hemosiderin, and the induration, the that woody texture of skin. Spots, blisters appear, which become hot and itchy, and where they're not treated, they can really cause further skin breakdown. They weep, there's irritation and infection, especially if your patient is the one that likes to scratch at their legs. We know that happens quite a lot. And worst case scenario, another wound can then develop, exacerbating the situation for the patient. And for you as a caregiver as well. So it prolongs your time that you've got these patients on your caseload. So this type of eczema can usually be controlled with a good skincare regime and compression therapy, although sometimes the individual might also require some topical corticosteroid or other types of skin treatment. But it might also be worth distinguishing between endogenous eczema and exogenous eczema. So endogenous is from within, exogenous is external forces. So for example, exogenous irritant eczema or dermatitis is a non-immunological inflammatory reaction, usually to a product. For example, the wool within the padding layers used under compression can be irritant to a lot of patients due to the fibres. Allergic eczema might be a reaction to something like latex. So if somebody's used gloves that contain latex, for example, lanolin, which is in a lot of products, or preservatives, the body produces antibodies and the skin becomes red, itchy, and becomes problematic. So you might need to look at the possible causes if you suspect that it's irritant dermatitis and exclude those products. And you can usually tell because it will be kind of in a certain patch on the limb. So do have a good close look at that and establish whether it is eczema that's being caused or dermatitis that's being caused from a product, or if it's generalized varicose eczema. Alternatively, obviously, if you're not able to solve that at source, then patch testing might be required for that particular patient. The next thing I want you to really think about, and it's a simple thing, but really very important, is hyperkeratosis. How often do we see hyperkeratosis on our patients? It's so common. So an abnormal thickening of the outer layer of the skin of individuals with lower limb issues, mainly caused by overproduction of the keratin layer, producing those horrible scaly brown or greyish patches. It's usually localised to the lower leg and foot and develops in response to inflammation as a rule. The degree of skin thickening will depend on its location. So, for example, the skin cells on the soles of the feet obviously might become thicker than those cells on the leg. But hyperkeratosis really does impact on the patient in terms of its appearance. It's dry, it's flaky, it's discoloured. It can be really, really unsightly. So it's important that we do something about it. And importantly, sometimes it really smells. There can be a very unpleasant odour caused by a buildup of bacteria or fungal colonisation under the skin flakes. So it's therefore, it really does require active management. And I'm sure that some of you will be pickers and some will hate picking, but ideally it does need to be removed. The problem we have, or actually don't have, is the time to do it. So in a busy day with appointments or visits every few minutes, it can be really hard to find the time. So we really need to employ an effective skincare regime to prevent this and to maintain healthy skin. And of course, we need to educate the patient on how to care for the skin themselves going forwards. So hyperkeratosis is one thing, and then there's generalised dry skin, obviously, which is something we see an awful lot of. We see the clouds of white skin as we take bandages off. But try to establish what the main cause of the dry skin is. The problem with dry skin is the impairment or loss of its protective capability against potential infection. Obviously, the skin is a barrier. So, of course, it can be uncomfortable, it can be itchy or maybe a bit stingy, as our body's normal process of shedding skin cells every 4 weeks or so is affected by the need for somebody to wear bandages or hosiery with leg ulcerations. So of course, soaking and washing and exfoliating gently with an added emollient should be considered wherever you can, given the situation, followed by emollient directly to the skin before reapplication of your bandages. Emollients obviously tend to be better than moisturisers as they're thicker and they add a layer to the skin surface, preventing moisture from escaping, whereas moisturisers and lotions tend to just moisturise. But sort of linking in with that, with emolliating legs, and folliculitis can be a real problem too for some patients. It's usually bacterial or fungal in nature. Very often it'll be a Staph aureus which causes it. It presents as pustules within or near the hair follicles with localised inflammation. It's frequently triggered by blockage of the hair follicle, and in my experience, especially where you use very greasy emollients, and so it can be exacerbated as well with infrequent cleansing. So it comes back to what we were just saying, you know, please try wherever you possibly can to cleanse the leg adequately. But it could also be caused by secondary infection as well, eczema or something like an insect bite, for example. So depending on the extent, this might again need antibiotic treatment if you think it's bad enough for that. So it really, if it doesn't settle, you know, you need to think about that. But the best means of management for folliculitis is prevention. So really take care when applying emollients. Use a downward action in the direction of the hair follicle to avoid them being clogged up with product and then becoming infected. So we seem to have covered quite a lot in a very short space of time, but venous leg ulcers and quality of life, as you can see from the slide I've just put up here, there is so much to think about with these patients. We can cover a lot of ground in the time that they're with us for appointments, but you know, it's the quicker we can get them healed, the better for them and for us. So the better we become with assessment, hopefully the quicker healing times progress. So we're often very good at focusing on the wound itself, sometimes to the exclusion of everything else. And there are so many factors that impact on a patient's quality of life. So this slide shows just a few. There is probably so much more that we could actually put on here. Some of these on here we can directly influence as clinicians, and some we can only influence indirectly. But where we assess really well and treat accordingly with consistent care and management, we can help to heal them faster. And where we can offer good, solid education to the patient, especially around diet, weight, exercise, skincare and prevention, we can help them to manage themselves as well. So as far as assessment goes, I'm just going to kind of leave that there and just let you have a little look at that slide. I don't think there's any need for me to read that out for you. It just kind of summarises some of the things that we've just talked about. So I'm going to move on now just for a few minutes to talk to you about something that's kind of gone off the radar for a little while actually. And I want to talk about zinc and ichthymol. Okay. So zinc and ichthymol is something that's really been tried and tested in wound care for decades. But as I've just said, it's probably recently fallen off the radar a little bit. So today, as well as talking about leg ulcer assessment, I'm here to tell you that zinc oxide and ichthymol is very much back on the radar. And I'd like to give you some information about these active ingredients and how they can help you to heal your patients. So let's move on to think about zinc. So zinc is really important for many functions in our body, including our immune function, including growth, antibody production, tissue maintenance, and wound healing. Now, zinc sulfate is widely available. You can pop along to your local health food shop and you can buy it in the form of supplements. And indeed, I actually did that a few months ago when the pandemic took off and started taking zinc supplements along with vitamin D when there was the news about vitamin D in an effort to avoid contracting coronavirus. Touch wood, so far it's working. So it's really good for our immune system and antibody production. Now, zinc is a metallic trace element, which is essential for your health, and it's second only to iron. So after iron, it's the second most abundant mineral within the human body, or it should be. And around 1/5 of our total zinc content is contained within the skin. You might not know that. I didn't know that actually. With the epidermis containing 5 to 6 times more than the dermal layers beneath. Okay. So it's required by all living things such as plants, animals, as well as humans, and topical zinc has been used in the treatment of wounds for over 3,000 years, since the ancient Egyptians used it to treat skin and eye lesions. I'm not sure I would want it on my eyes, but anyway. Yet our knowledge of the benefits of using zinc as an active ingredient appear quite limited. And certainly from the perspective of Evolan's products, Ichthyopaste, Viscopaste and Zipzoc, many clinicians have known and used them for years and years, including myself. However, it came to light to me that many people didn't really fully understand why they worked so well. People loved the products, but didn't really understand why they were as good as they were. And of course, there are some newer nurses that are coming through, younger nurses that maybe hadn't even heard about them because they'd fallen off the radar a little bit. So I started to work with Evolan after they acquired the products a couple of years ago. I absolutely love the products. I'd used them for years in my nursing practice and seen some really great results with them. Yet they're so simple and cost effective. But they're now being used again widely across the UK to help, in particular, heal leg ulcer patients. And they're also heavily used in dermatology departments in the main. So I'm going to have a little think about how zinc works in wound healing. So zinc, if I can explain this to you, is actually located intracellularly and in the extracellular matrix of the skin in the form of protein complexes. And its role is really to stabilize cell components and membranes. And that action actually aids cell division, migration and maturation, which, as you probably know, is all a vital part actually of the wound healing trajectory. So zinc is therefore vital for cell structure and integrity. And unlike other minerals and vitamins, there are no body stores of zinc, and therefore it's important to have a well-balanced diet with a daily intake of zinc to maintain adequate body functions. And I mentioned diet earlier, and patients need their calories to be derived from a diet rich in variety, as for example, deficiencies in fats, carbohydrates, and vitamin A might lead to impaired immunocompetence and an increase in the risk of infection, whilst a diet deficient in protein, vitamin C and zinc all contribute to poor wound strength. So a zinc deficient diet is the most common cause of systemic deficiency, and ironically, the individuals who are most susceptible to zinc deficiency are those who have the highest physiological demand. So that might be our elderly population who are affected due to a poor diet maybe, or an age-related decline in zinc absorption. And additionally, it's often the elderly population who are likely to suffer a higher prevalence of comorbidities predisposing them to hypozincemia, including things like malignancy, chronic wounds such as venous or arterial ulcerations, and dermatological disorders as well. So consequently, wound or skin healing really can be delayed for those patients. So looking at literature over the years, it's been reported that chronic leg ulcer patients will often have an abnormal zinc metabolism and low serum zinc levels. So if we could check them regularly, we might find that with these patients who are oozing fluid over a long period of time. So therefore, consideration should really be given to maintaining normal zinc levels when you're treating those patients. So over several years, the poor wound healing status in patients with zinc deficiency led to studies being carried out to identify the effectiveness of oral zinc supplements, like what I'm taking from the health shop, versus topically applied zinc oxide, with the aim really of developing therapeutic approaches to enhance wound healing. And it was found by Magnus Agren way back in the 90s. He identified that zinc oxide, when it's applied to skin, it's slowly but continuously solubilized when it's applied to an open wound. And when you put it on human skin, it does increase zinc levels in the epidermis and the interstitial fluid and the dermis. So thereby, not only correcting a local zinc deficit and enhancing wound healing, but it also acts in a pharmacological way as well. So a further review of the literature showed that oral zinc supplementation actually failed to confer any advantage in healing rates. Okay, so actually in healing rates. However, topical zinc oxide has been shown to improve healing rates regardless of patients' zinc status. So studies show that the application of topical zinc oxide, they also showed that it soothes red and irritated skin. It helps to reduce wound debris, it helps to improve healing rates, and it promotes epithelialization in the wound as well. It provides antioxidant, antifungal, and antibacterial actions as well. So there's really a lot that zinc has to offer. Okay. Now, one of the other ingredients that I wanted to talk about, one of our active ingredients, is ichthymol. And some of you have probably, maybe nurses who are around my age might remember ichthymol. We used to put that on cannula sites when they'd become inflamed sometimes where I worked. But ichthymol is a multi-component cellular mixture which is derived from sulfonated shale oil. It's actually mined from ancient marine materials, but it's been frequently used in dermatology departments since the 19th century, and it used to be used as a drawing salve, which is quite interesting. It was used to help hasten the pointing of boils and abscesses. So over the years, that led to reports that ichthymol actually improved blood flow, because you know when you put something on to draw something out, you can feel that pulling. But with a full history dating back to the early 1300s, when the first recorded use of shale oil in medicine was recorded, ichthymol is now, as I say, mined in France, originating from marine material. And for decades, really, it's been employed in healthcare for the treatment of eczema, dermatitis, psoriasis, leg ulcers, furuncles and pustules, and all manner of different things. So today, it really does remain an important medicament in the armoury of the dermatologist. And there was some work done by a guy called Geico, which referred to the actions of ixtamol, stating that it has manifold pharmacological actions. So its application for the treatment of inflammatory skin conditions has been well established since the days of the Unna boot that was cited, the work carried out by Paul Unna back in the 1800s. It's been cited in many other documents since. So besides its ability to treat inflammatory skin disorders, ixtamol possesses antibacterial, antimycotic and antipruriginous actions. It's really useful in treating wet, itchy eczema, helping to break the itch scratch cycle, and really good to use for dermatitis and psoriasis as well. So it also contains fat, and ixtamol provides a layer of oil on the skin surface, which helps to prevent moisture from evaporating. So very similar in a way to an emollient, keeping the skin well hydrated. And for patients with chronic lichenified skin conditions such as eczema or hyperkeratosis, when combined with the properties of zinc oxide, Ixapace bandage is a really suitable therapeutic product for symptom relief and maintenance of the skin's integrity. Now, of course, probably the drawback to both zinc oxide and ixtamol as a raw ingredient is it would be a bit messy. So obviously now we have these products combined within bandages and products. There's lots of other products out there that contain zinc oxide as well. But as zinc oxide and ixtamol is predominantly used to treat chronic dermatological conditions and lower limb ulcerations, obviously Viscopaste and Ixapace cotton bandages and Ziploc medicated stocking provide a really convenient and easy method of using zinc oxide as a topical healing agent. And they do offer a good level of comfort, so they're particularly tolerated well by most patients. In terms of indications for our three products, and these are what we legally can claim, you can see from the slide they're suitable for wet and dry ulcerations, along with a myriad of other skin conditions. So in addition to acting pharmacologically at the wound site and increasing zinc levels in the wound area, the skin is also improved by the addition of the topical zinc oxide. And in particular, varicose eczema responds exceptionally well to zinc oxide and ixtamol, but also hyperkeratosis is really well improved as well. And as we've already mentioned, the anti-inflammatory properties help to settle and soothe inflamed tissues in cellulitis and red leg syndrome as well. So in dermatology, all three products have been used for many years to treat and manage skin conditions like atopic eczema, dermatitis, psoriasis, to name just a few. So you can see from the list as a company what they claim are their indications for use. So I'll just let you read through that. In terms of contraindications, well, really, there are very few. The only thing that we say is to avoid using them on diabetic ulcers. And the main reason for that is because they do apply a high level of hydration. So we don't want to overhydrate and macerate a diabetic foot ulcer. And the only other time that we contraindicate is where there is any known sensitivity to zinc oxide or any of the other ingredients within the product. So if somebody's had a patch test, then obviously you wouldn't be using it. But otherwise, there's really very little to say about contraindications. What we do say, though, if it's the first time of using the products for any of your patients, it is good practice to always patch test before use. We recommend that you carry this out for a period of 48 hours. Just apply a small patch onto the patient's back. That's where we would normally say to do it. Cover it over and leave it for 48 hours. And provided there's no unwanted reaction, then you're absolutely fine to use it. And to be honest, we rarely see any reactions at all. Especially given that Ziploc in particular is preservative free, it has a very much lower potential for sensitivity. So in terms of the products, Viscopaste actually is the mid one of the three, contains 10% zinc oxide. Ichthyopaste has 6.32% zinc oxide and 2% ictamol, which we talked about. And Zipzoc of the three is the highest amount of zinc oxide at 20%. And Zipzoc is presented in a cotton bandage. And the only other ingredients in there are white soft paraffin and liquid paraffin. So there are no preservatives in Zipzoc, which makes it a real good choice for those patients who are likely to react to many things. So that's kind of the main difference between them. But obviously, Viscopaste and Ichthyopaste is presented in the form of a bandage, whereas Zipzoc is a stocking. Because of the higher amount of zinc oxide in Zipzoc, it is classified as a pharmaceutical product, whereas the other two are class 3 medical devices. Now, in terms of application, well, very, very simple, certainly for Zipzoc. Zipzoc is a stocking. It's pulled on as easy as pulling on a sock. We always recommend, if it's on the lower limb, to put it toe to knee, and then obviously you need to cover it over to prevent the patient's clothing from being soiled. You can cut it if you need to. Remember, it does stretch laterally. It has elastic fibres in Zipzoc, so therefore when you apply that, if you cut it, it will shorten slightly, so just be mindful of that. The bandages have no elastic fibres at all. So therefore, we always recommend to either cut it into strips and apply to the affected area, or simply to do a pleating technique. Now, we don't have the time today on here to show you the pleating technique, but if you visit our resources, we do actually have a very short tutorial on how to do the pleating technique with the bandages, and it also shows how to apply Zipzoc as well. It's just a short 7-minute watch. It's available on our homepage as well, which is www.pastebandageseverlan.com as well. So please do make your way to that and have a look at the application, because it is important, because especially with the bandages, there's no elastic fibres. They do tighten slightly a little bit, because obviously your body absorbs the paste, so they do tighten a little bit. And during the inflammatory stage of healing, you would expect some swelling to take place. So the bandages need to be applied in a way that the swelling can occur. Okay, so do pleat. That's really, really important. Just a couple of things just to mention. The products can all be left in place for up to 7 days. They're all single use, and then they need to be removed, maybe wash the leg if you can, and reapply. Depending on the treatment plan, they might need to be changed a little bit more frequently as needed. We do know that in dermatology, they tend to tell their patients to change them a little bit more often. But when you're removing them, please always unwind bandages. Don't cut them, because if they've dried slightly, you know, it could be a little bit unsafe to actually cut them away. So please do unwind them rather than cutting, and just make sure that you store the bandages well. One more thing to mention, just a little bit of a myth really about steroid creams. We get this question all the time. Can you use steroids with zinc paste bandages? Yes, you absolutely can. There's no reason why not. You just need to be mindful that if you are using a steroid, or maybe also an antibiotic, a retinoid, or an anaesthetic topical preparation, the nature of occlusive bandages is to increase absorption. And therefore, the uptake of the topical preparation might be increased. And so it would lead to a shorter duration effect. So you just need to be mindful of that, but you absolutely can use steroids. Although I would say, if you're going to use zinc oxide, why not just give it a try? You might not actually need the steroids as well. So I think we've covered lots of information in a very short space of time, and of course we could talk all day about venous leg ulcers. And training for leg ulcers is a very practical thing, especially with vascular assessment. But I hope that today's short session has given you a few things to think about in terms of your process of assessment for the patients. Trying to look at all the factors involved to implement a clear plan of treatment, and to consider how you might improve healing rates by using zinc oxide and ictamol maybe, which will act pharmacologically, and to maintain the integrity of your patient's skin as well as increasing those important local zinc levels at the wound site. Paste bandages and stocking have been used in wound care for so many years. They really are an important and unique product to use in leg ulcer and lower limb management. So I hope today has been useful. We've got this guy here with the bandages on his arms, not forgetting also that they can also be used in dermatology for different conditions as well. I'm going to just leave you with this slide here with our resources from Evelan. You're available to download today from the conference site. You can also view the short product tutorial that I mentioned earlier, which details the application method of the products. That's also available on our homepage, www.pastebandagesevelan.com. We also have a Facebook page, it's on there. We also have a LinkedIn page as well. And of course, should you require any further information at all, or you want to book a training meeting, please do contact me. And at this point in time, I'd like to thank you all for your time today and for all your hard work during the last extremely challenging year. And I'd like to invite any questions. Hi everybody, so thanks for watching our presentation, and I'm going to just spend the next 5 minutes or so just to look at some of the questions and see if I can provide you with some answers. So let's see what we've got. So first of all, Thomas asks, what's the main differential symptom or sign that indicates red leg syndrome or cellulitis? And I think the most important thing to differentiate between the two is if a patient has acute cellulitis, the likelihood is that they will be extremely ill. Obviously, it can be a bit more mild, but when it becomes more serious, that patient will be systemically quite ill. With red leg syndrome, that shouldn't be. They shouldn't actually be feeling ill. The other thing to mention is really that cellulitis will usually be unilateral. Okay, it's rarely bilateral, and more often than not you find with red leg syndrome that will be bilateral. And then I think the other thing really to differentiate between is the pain level. Really, you will have some swelling, some tenderness, some warmth with red leg syndrome, whereas with acute cellulitis it is going to be extremely painful. So there's a few different things to take into account, obviously, when you're kind of trying to diagnose between the two, but they're the key differences for differential diagnosis. Okay. Shirley is asking, what's the best way to address malodor to make this less distressing for the patient? And yeah, that's a really difficult one, isn't it? Because we do know that patients are often quite distressed by the smell of a leg ulcer. But I think really the key way forward is to manage the underlying conditions, really. So obviously we've talked about a few things in the presentation, looking at the wound bed, is there any infection there? We need to deal with that if there is any infection there. You might see a darkening wound bed, you might see some erythema and tracking. So dealing with infection. The other thing is thinking about the tissue type as well. We've said already that slough and debris always builds up in any wound, not just the leg ulcer, in any wound. And sometimes that can start to develop malodor as well. And obviously if there's any necrotic tissue, that really needs to be debrided. So I think a good debridement management technique, whatever's on your formulary, use that to try and clean the wound as best as possible. And then it's things like thinking about a really good skincare regime. We talked about hyperkeratosis, and hyperkeratosis, as I say, does really smell. So a good level of hygiene. I know that's really difficult sometimes to actually manage to be able to wash patients' legs, but if you can only do it once every now and again, it's better than nothing. So certainly managing the skin, managing hyperkeratosis, things like that, making sure that the bandages are being changed adequately, sufficiently frequently, really, so that it's not becoming a bit smelly with that. And then I guess ultimately, if all of that fails and you can't stop the malodor, then there are obviously dressings out there, charcoal dressings, for for example, that you can use. So I would say think about all of those things and see how you go, but ultimately you might need to think about different types of dressing as well. Juliet asks, would you do compression bandages for these? And I think your question came through at around about the time we were talking about red leg syndrome. Yes, if your patient with red leg syndrome isn't in compression, it's usually quite optimum to get them into compression. So I think that's what you're meaning with that question. Lindsay, what is the best way to remove hyperkeratosis? Well, really washing and a good cleansing regime. Use some emollient in the water, a good soap substitute to clean and cleanse the leg, pat it dry. Obviously, I think I mentioned in the presentation, some people are pickers and some people love to pick, don't they, and find it really, really therapeutic. So get your forceps, your plastic forceps, try and remove as much as you can. But the good hygiene regime should really, really help. And if it doesn't, obviously we've talked about zinc products. They are really good for chronic lichenified conditions. So like hyperkeratosis and like eczema as well, things like that. It is really good for to soften and to keep the skin in good condition. Adetutu asks, is there any contraindication to the use of zinc oxide? So the only contraindication, if you're talking about zinc oxide as in a bandage, so as in visco paste maybe, or in Ziploc stocking, the only contraindication that we say is if there's been any known sensitivity to zinc in the past. So if somebody's shown a sensitivity, obviously you're not going to use it on those people. But the main thing really is that we say not to use our bandages on diabetic foot ulcerations. And that really is just to kind of avoid that hyperhydration, really. So other than that, we don't really contraindicate against using the bandage. They're very simple. That's all we tend to say. Okay. Nigel's saying, I get staff to clean the hyperkeratosis. He finds it therapeutic. So does a lot of people. I do too, Nigel. It does take time, though. You're absolutely right. It takes time. So what Nigel's saying, he's got one of the support workers, the HCAs, to undertake that task. And I think that's a great idea if you've got somebody working with you that can do that, just to really cleanse the limb, pat it dry, get your forceps, take away those flakes of skin, and then really emoliate it well. So that's a great idea. Bola is saying, would you use zinc in eczematous venous ulcers or chronic ulcers then, please? So yes, you can use it for eczema, whether that be varicose eczema or atopic eczema. You can do that. All ulcers, as I've just said in the previous question, you need to be very careful around diabetic ulcers. We contraindicate for those, and also obviously just be mindful for arterial ulcers as well. So our main indication, what Everland will say about the indication for visco paste and for Ziploc, is that they're indicated for venous leg ulcers and their associated skin conditions, and obviously the dermatological conditions as well. So most chronic ulcers, if they're venous in nature, yes, you can, but just be careful around diabetic and arterial ulcers. Okay, we'll just do a couple more. Leanne is asking, can you use ichthyo paste or visco paste or zinc oxide as a patch? And she says, I thought it was licensed not to be used in this way. So I think, Leanne, if I understand what you're saying correctly, you mean, can you just put it, say, in a patch, say, for example, on an arm? Yes, you can. Or if it's on a leg, you can cut it into strips and you can apply just to the affected area. We do normally say with a lower limb to apply toe to knee. That's kind of something that we've always said with the bandages. But you can put them on as a patch if you prefer to do so. But for the majority of people, they will will apply them toe to knee and then either apply compression bandaging or another compression system over the top. But yes, you can. There's nothing in relation to a license to say that you can't do that. What we do say is don't just spiral the bandage on. Just because of the inflammatory response that you get in wound healing, the swelling occurs, and what you don't want to do is to make it tight. Okay. And then we have Michaela, who says, could you use the zinc products for bullous pemphigoid? That's actually a new question, to be honest. I would say you probably can. Obviously, make sure that your patient has no sensitivities to zinc. But as it is a skin condition, a chronic skin condition, yes, you probably could do that. You could give it a try. But as I say, we always say to patch test for 48 hours if it's not been used on that particular patient first. So do patch test and make sure there's no unwanted reaction. And then last one, Joanna says the zinc can leave a residue and fibres on the skin, so is it best to wash the leg in water and emollient before each application? Goes without saying, absolutely. If you can do that, please do. Obviously, I'm a nurse myself. I understand the pressures. It's difficult. Just do whatever you can in terms of cleansing, but it is kind of beneficial if you can wash the limb. Okay, so I think we've almost run out of time now, so we'll leave it there. Of course, I can be contacted. You will have seen my contact details within the presentation. If you have any further questions, please contact me. I am here. I'm working through the pandemic. I'm here to support you with anything that you need going forward. So please pick up my contact details. And we've now come to the end of the final session for this week for the PCN Live, and I'm sure you'll agree it's been a really fantastic week and a lot of great speakers this week. So I'd like to say, first of all, a big thank you to Everland, who were your sponsors for this afternoon's session, but also a huge thank you to the Mark Allen Group, the Practice Nursing Journal, Independent Nurse, the British Journal of Community Nursing, and the Journal of Prescribing Practice. It really is great that we can still have these events and we can adapt and connect even through the pandemic. So really grateful to the Mark Allen Group for putting on the sessions this week. It's been fantastic. And finally, to all of you, hope you've all had a great week as well, and that you'll take away some really useful information from the sessions that you've managed to join this week. And I think I said before, but once again, just thanks to you all for all your hard work. It's been the most horrendously challenging year for nurses and for clinicians generally. So thanks for all that you're doing for everybody. So thanks for listening. Bye for now and take care. Thank you.